Hi, welcome. Good afternoon. I hope you can hear me. You can probably not see me because the lights will come out just now due to load shedding. Anyway, welcome. Gecko is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. And Gecko, as you know, Gecko Fellows is run every second Monday at 6 o'clock. During the presentation, the chat will be open for questions. And we will address that sometimes as we go along in the chat, or we will leave enough time for discussions at the end. Our presenter today is Desiree Moodley from University of Stellenbosch and Tygerberg, and she's going to talk on a very interesting topic of liver abscesses and cystic liver disease. And I'm Christo Kloppers. Okay, Des, over to you.
Can you see my screen?
Yeah, positive.
Okay. So yes, as mentioned, today I'm going to be talking about liver abscesses and cystic liver diseases. It's a mammoth topic, so I'm going to try to get through as much as I can. Thanks to Prof. Christo for his help. So starting firstly with cystic liver diseases. So liver cysts are heterogeneous lesions. Their prevalence in the United States is about 15 to 18%. Most of these lesions are detected incidentally on imaging. We don't really have numbers for sub-Saharan Africa, and the way they present varies based on the pathogenesis, clinical presentation, and also radiological findings. They're only symptomatic in about 10 to 15% of people, and the vast majority are benign. Simple cysts account for 2.5 to 18% of these. Congenital cysts are more common in females with the age of about 40 to 70, and acquired more common in males with a predominance age of 30 to 50 years. So when looking at hepatic cysts, we can separate it into infectious and non-infectious. So infectious, which I'll talk about later, would be parasitic, such as hydatid cysts and amoebic abscess, and non-parasitic, such as pyogenic abscesses and fungal. Then looking at your non-infectious hepatic cysts, you've got your benign ones, which I'll talk about, and pre-malignant. I don't really go into malignant and trauma in this talk. So hepatic cysts are fluid-filled lesions. Sorry, I just want to close this, yeah. Fluid-filled lesions lined by a single cell layer, either in the hepatic parenchyma or in the biliary tract. Of the non-infectious type, there's three main types: fibrocystic liver disorders, which are due to bile duct growth plate abnormalities; mucinous cystic neoplasms, which were previously called cyst adenomas and cyst adenocarcinomas; and then hydatid cysts. So the fibrocystic liver disorders consist of about 7 different types of cysts, and I'll now go into these. So starting with the most common type, simple cysts, these are congenital. Females more than males with a ratio of 1.5 to 1, and age most common at 50 years. So this is due to aberrant bile ducts with no communication with the intrahepatic biliary tree. So these bile ducts continue to secrete intraluminal fluid, and hence they grow. Usually they're asymptomatic if they're less than 3 centimeters in size, solitary, or multiple but less than 3. They consist of a single layer of cuboid or columnar epithelial cells with up to about 2 septa. They can be symptomatic or complicated. These complications include infection, intracystic bleeding, and rupture, which is rare, only really when the cyst is over 10 centimeters, and commonly with trauma. Rupture can also result in infection as well as hemorrhage, and it can also rupture due to trauma. Oh, sorry, I mentioned that, and intervention. You can also have symptoms due to compression of adjacent organs, commonly the bile ducts in segment 4. So this is just a CT on your left and an MRI on your right, both showing just a simple hepatic cyst, single lining with no septations in both. So ultrasound is the best imaging modality to diagnose these cysts. If it's asymptomatic, leave it alone. No follow-up indicated. CT and MRI is advised if they are complicated, and this will determine your intervention and also if the patients need surveillance. In terms of aspirating the cyst or doing serum for CEA or CA19-9, there's really no diagnostic value. The tumor-associated glycoprotein 72 or the tag 72 is quite helpful in differentiating a simple versus a mucinous cystic neoplasm. If it's more than 25, it's more suggestive of a MCN with a sensitivity of 79% and a specificity of 97%. So when do we manage these? When they're symptomatic, with volume-reducing therapies. So one of the ways is doing percutaneous aspiration sclerotherapy. This is when you aspirate and then inject a sclerosant such as 100% ethanol, 20% saline, tetracycline, or polidocanol. This results in symptom relief in about 3/4 to all patients, with resolution in half to 100%. It can take up to 6 months to work, and it can result, especially if it's 100% alcohol, you can get alcohol intoxication as well as local pain. And this also depends on the duration of the injection of sclerosant as well as the volume of alcohol used. It's contraindicated with fistulas and if there's any sort of hemorrhage in the cyst. Just to note, with percutaneous aspiration sclerotherapy, recurrence rates are higher. If you go for cyst fenestration, which is doing a laparoscopy, drainage, and then excising the cyst wall, this results in recurrence in only, less than 8% of patients. For multiple and large simple cysts, you can consider a partial hepatectomy and fenestration. However, this has quite a high perioperative mortality of 14%. And they say that these patients can progress to liver failure with a mean of 6 to 8 years, with the need for liver transplant in these patients of 2 to 3%. If you have a complication of cyst hemorrhage, so this is one of the most frequent complications that can occur in a simple cyst. This is injury to fragile blood vessels of the cyst wall lining, more common if it's more than 8 centimeters in size, and this can happen spontaneously after you've performed an intervention or a rupture. So they have sudden severe pain in most patients, which will resolve within a few days, or just localized pain that resolves within days to weeks. And it's very rare that this causes hemodynamic instability or a drop in your HB. This is some imaging of a patient that's got a hemorrhage. So A, you can see the septations that don't enhance, and that's a hemorrhage. B and C, so in B, you can see on the T1 that the hemorrhage with the septations tends to light up. C, the cyst lights up, but not so much septations. And then in D, there's a nice, it shows the calcification that can occur after the cyst has hemorrhaged. So how do we treat it? Conservatively. You kind of avoid any interventions while it's actively bleeding. If the patient's on any anticoagulants, you're going to stop them and restart 1 to 2 weeks after the onset of hemorrhage. Restart earlier if the patients are high risk for thromboembolism, and there's really no role for vitamin K, PCC, or fresh frozen plasma unless there's any hemodynamic instability. If they're on aspirin, you're going to omit it for 3 days, and if they're on dual antiplatelet therapy, you're going to continue clopidogrel, once again omit the aspirin for 3 days. If there's any infection, so when can you make the diagnosis of a hepatic cyst infection? You've got definite criteria and likely criteria. Definite criteria is if you've aspirated the cyst and you have any neutrophils or you grow in a microorganism, then you can say there's a definite infection. There are clinical findings that suggest a likely infection. So this would be a fever of more than 38.5 for 3 days. And you've excluded other sources of fever, UTI, pneumonia, etc. If you've got tenderness in the right upper quadrant, a raised CRP, white cell count, or positive blood culture. And then if you have imaging findings suggesting infection, so a CT or an MRI that has gas, or a FDG PET that shows increased FDG activity lining the cyst, or even an ultrasound that shows debris with a thick wall or a distal acoustic enhancement would suggest a cyst infection. If you suspect cyst infection and you've treated it, you should treat with fluoroquinolones or third-generation cephalosporin for 4 to 6 weeks. Just to note, carbapenems and cefazolin have very poor penetration. So initially, you just assess the patient, do a SOFA score, check for organ dysfunction. You're going to tailor your antibiotic therapy to blood cultures. And if you've aspirated the culture of that, adjust your therapy to local resistance, adapt the drug dosage if they've got renal impairment. And if they're not getting better, you could consider fungal cover as well. You can say it's successfully been treated if the symptoms resolve, including fever, your CRP normalizes, and you've got negative blood cultures ×2. When should you drain these? If your temperature is persistent after 2 days on empirical antibiotic therapy, that's appropriate. If you've got pathogens that will be unresponsive to antibiotic therapy, severely immune compromised people, a CT or MRI that shows gas, and if it's a large infected hepatic cyst. So more than 5 centimeters, you can consider draining it. Moving on to polycystic liver disease. So this is very, very rare, 1 in 10,000 to 1 in 158,000 people. This is when you have 10 liver cysts that are unconnected to your bile ducts. There are 2 components. You can have autosomal dominant polycystic kidney disease or polycystic liver disease. There is an earlier onset and faster progression in females, and this is thought to be due to a component of estrogen. They range in size from 2 millimeters to more than 10 centimeters, and they have a single layer of cuboidal or columnar epithelium, and it resembles that of bile ducts. Very, very rarely you can have squamous epithelium lining it, and that puts you at risk for squamous cell carcinoma. So with polycystic kidney disease, renal disease predominates. However, you will have liver cysts by the age of 30 in a quarter of patients, and 80% of them will have liver cysts by 60 years. Other organs can be frequently affected, your pancreas, your spleen, they get diverticular disease, hernias, mitral valve prolapse, Biliary aneurysms. And then in polycystic liver disease, interestingly enough, only about 2 to 5% are symptomatic. This is just a picture. So you have multiple genetic mutations that affect the proteins that encode for transport of fluid, as well as your epithelial cell lining, which is what results in these cysts being formed. As you can see, multiple genes have been identified. And they present usually asymptomatic, as I mentioned, and symptoms in females tend to be a bit more severe. They have larger cysts and more numerous cysts. They can present with abdominal pain, discomfort, postprandial fullness, basically mass effect, as well as a large liver, dyspnea. And if they have severe pain, then you need to suspect a complication, such as infection, a hemorrhage or a rupture. They can also have jaundice, depending on where the cyst is sitting. And if it's ruptured, they may have ascites, hepatohydrothorax, and really can also have pulmonary portal hypertension, especially if they also have congenital hepatic fibrosis. This is just a table that summarizes everything I've just said. So how do we diagnose polycystic liver disease? Well, your LFTs are normal. They can be mildly elevated ductal enzymes. Your CA 19.9 can be elevated as well, but none of this really helps you. So we confirm it on ultrasound, or if it's complicated, CT and MRI. The KDIGO says that every person who has autosomal dominant polycystic kidney disease should have an ultrasound to screen for polycystic liver disease. If you've got family members, you don't need to screen them unless they have symptoms. Generally, liver volume will increase by 1.8% annually, but in females, as I mentioned, with the estrogen, it's actually 4.8% by up till the age of about 40 and then menopause. And this is a prognostic marker. So you counsel your patients on the growth pattern, especially if symptoms arise, and they should be followed up at expert centers. As I mentioned, no need to really screen the family, and there's very little room for genetic testing. It doesn't really change your management. So this is just a CT showing a patient with polycystic liver disease, multiple cysts in the liver and kidney. So how do we classify it? So there's multiple classifications. The GIGO criteria uses the amount of cysts and the amount of normal parenchyma in the liver. So type 1 is the mildest form. You've got less than 10 large cysts that are more than 10 centimeters. Type 2, diffuse involvement of the liver and parenchyma. You've got medium-sized cysts, but you've got large areas of normal liver parenchyma. And then type 3, the most severe, different size liver cysts, very smaller areas of normal liver parenchyma. Keown's classification is another one mentioned in the guidelines. This is just mainly used for family members to screen them, and it just goes by how many cysts are found. Schnelldorf was also mentioned. This is looking at the types of cysts, whether they're complicated or not, and if a patient has symptoms. So looking at it from an algorithmic point of view, once you have a patient with polycystic liver disease, you should stop exposure to exogenous estrogens, and then it depends on whether they have symptoms or not. No symptoms, you're not going to treat it. If they do have symptoms, in a stepwise approach, depending on how big the cysts are, initially you'd start with medical management, such as somatostatin analogs. If it's large and strategically located, you could then consider aspiration sclerotherapy. Single, multiple, large superficial cysts, cyst fenestration. If it's cysts that are clustered in a certain segment of the liver, that's when you could consider a liver resection. And if it's massive disease, to consider liver transplant. But I'll go into that now. So in terms of stopping the exogenous estrogen, so if it's a female of childbearing age, she could be on a levonorgestrel IUD, and pregnancy is not contraindicated. If they have complications such as rupture, hemorrhage, or infection, treat that symptomatically. If they have hepatic vein obstruction, you could consider hepatic vein stenting. So in a study where they looked at how many people had this, 78% had a moderate obstruction and 22% had a severe. If they've got other systemic complications such as mitral valve prolapse, refer them to a cardiologist. Family history of Biliary aneurysms, then you're going to screen them. No family history, then you'll counsel on risks. Malnourishment is something that is often underestimated. So they get a mass effect, compression of the stomach, poor intake, but because the kidneys sometimes weigh a lot and the liver weighs a lot, we underestimate it. So somatostatin analogs can be used, lanreotide, octreotide. This decreases the liver volume and increases your intake, but it's got no real effect on your nutrition. The biggest reduction is seen in the first 6 months, and this works quite well with young women who have rapidly progressive disease. Just to note, you can get steatorrhea, cholelithiasis, it can affect your glycemic control and cause alopecia. I also suggest doing a CT scan for sarcopenia. And once you've diagnosed this, do intensive nutritional optimization and exercise. And if at any point the patient's not getting better, look for indications for liver transplant. So this would be any clinically apparent liver disease due to massive polycystic livers affecting your quality of life, or if they've got complications that include severe malnutrition, hepatic venous outflow obstruction, ascites, portal hypertension, variceal hemorrhage, and recurrent infections, as well as if you've done non-surgical treatment and it's not improving. Also consider doing combined liver kidney if the creatinine clearance is less than 30. Moving on to choledochal cysts. So this is just to refresh us about the Todani classification for choledochal cysts. So type 5 would be your Caroli disease. So you have a ductal plate malformation of your large intrahepatic bile ducts. You've got a failure of remodeling and resorption of your ductal plate during fetal development, and then you have persistent embryonic biliary structures. So this is it's on the spectrum of autosomal recessive PKD. To make the diagnosis of autosomal recessive, you need 2 genetic mutations. Caroli's disease, you have 1, which is the PKHD1 mutation. So you get multifocal segmental dilatation of your large intrahepatic ducts. It becomes Caroli syndrome when you have that, as well as involvement of your small intrahepatic ducts and congenital hepatic fibrosis. This is a premalignant condition in that about 7% of them will continue on to become cholangiocarcinoma, which is much higher than the general population. This is thought to be because of the carcinogenic effects of chronic inflammation. They get recurrent cholangitis, as well as biliary stasis and the formation of carcinogens due to permanent biliary irritation caused by gallstones. So on the left, there's an MRI. It's a T1 weighted MRI. It shows multiple hypodense cystic structures that you can see are connected to the biliary tree. And then on the right, it's a T2 weighted MRI, and that's also showing the same hyperintense cystic lesions. So they can present with cholestasis that can lead to stone formation or cholangitis or abscesses. They can also have liver fibrosis if it's a Caroli syndrome. This can be assessed. They suggest doing non-invasive methods to assess this. They may have portal hypertension and, as I mentioned, cholangiocarcinoma. It's also not uncommon for them to have renal involvement with dilatations of your collecting ducts and distal tubuli, and thus they may have some element of renal impairment. So management-wise, if they have cholangitis, you're going to give antibiotics, treat them with an ERCP. If they have stones, they should be on ursodeoxycholic acid at 13 to 15 milligrams per kilogram per day. They actually suggest that all patients, even those without stones, should be on ursodeoxycholic acid. If they have abscesses, we should drain them, and then you're going to monitor them for complications, especially not to forget osteoporosis. For surveillance for cholangiocarcinoma, they should get a yearly MRCP after diagnosis, And ERCP shouldn't really be done routinely for cholangio screening. For surgical management, so liver resection can be done. It does relieve the symptoms, especially if they have restricted bile duct involvement. We should consider liver transplant if they keep getting recurrent cholangitis and both lobes are involved, or if one lobe is involved, but they also have liver fibrosis or portal hypertension, and liver resection is not an option. Cholangiocarcinoma, they say, is a contraindication for liver transplant, but there was a study done that showed that it could be done if the cholangio is less than 2 centimeters. This is, however, associated with a high recurrence rate of up to 75%. Biliary hematomas also can be referred to as von Meyenberg complexes. So this is part of the spectrum as well of ductal plate abnormalities. And they can occur in a normal liver, can also occur with Caroli disease, congenital hepatic fibrosis, and your polycystic liver diseases. So these are tiny, so less than 1 centimeter, hypodense lesions throughout the liver, and usually have a normal intrahepatic and extrahepatic ducts. Typically 2 millimeters to about 1 centimeter, and you get this kind of starry sky appearance. If asymptomatic, there's no need to follow them up. So this is just an MRI showing you these cysts, and then on the right, the kind of the starry sky appearance. Okay, so that's it for the non-malignant cystic lesions. Now we move on to mucinous cystic neoplasms. So these are very, very rare, less than 1% of all liver cysts. Seen more commonly in females in the 5th to 6th decade. Most of them are centrally located, but they can be found in the right or the left lobe. And it's basically a cystic epithelial neoplasm that can be lined by cuboidal, columnar, or flattened mucin-producing epithelium overlying ovarian-like hypercellular stroma. Their size can vary. They can go from 1.2 centimeters to a whopping 40 centimeters with a mean size of 15. The vast majority of them are benign, but about 3 to 6% can progress to invasive carcinoma. So the nomenclature was changed. So previously it used to be biliary cyst adenoma and biliary cyst adenocarcinoma. They're now known as non-invasive biliary MCNs and invasive biliary MCNs. To make this, you need ovarian-like stroma for both, and it should not be communicating with the typical bile duct. If it does communicate with the bile duct and there's no ovarian-like stroma, it's now classified as an intraductal papillary mucinous neoplasm of the biliary type. So as I mentioned, you get a cyst-forming epithelial neoplasm. So inner lining is cuboidal columnar cells, which produce mucin. This is lined by the subepithelial layer of the ovarian stroma, and then your dense collagenous layer on the outside. That's made of connective tissue. So this separates the cyst from the liver parenchyma, and it can actually provide a surgical plane for enucleation. So they're commonly symptomatic, 86% of patients. And these are, once again, mass effect, abdominal pain, fullness, early satiety, and then they can be low-grade dysplasia, high-grade dysplasia, or invasive carcinoma. So there are certain features that worry you when you look at a MCN, and these would include, so one major and more than one minor can be considered as worrisome features, and then you would do an MRI to characterize these cysts. So the major ones are thick septation and nodularity, and your minor ones would be upstream biliary dilatation, thin septations, any hemorrhage, perfusional change, and if you've got less than 3 cysts that are coexistent. You can also use the tag 72, as I mentioned here, to help you differentiate if you're not sure if it's a simple or a cyst or a MCN. So on CT scan, these are typically solitary, large, well-circumscribed cystic lesions. They're multiloculated, the vast majority at 90%, or they can be unilocular, mainly in the left lobe of the liver. As I mentioned, they often contain enhancing septa, mural calcifications, and mural nodules, and the latter is associated with malignancy if it's bigger than 1 centimeter. This is just showing some imaging. So you can see in A that you've got these very thick septations over there. B and C show those thick septations as well. And then D is just the pathological appearance. So the mainstay of management here would be surgery. You want to completely resect these lesions with negative margins, whether it be peripheral or the entire liver lobe. If it's central and it involves major vascular or biliary structures, enucleation is an option. Things like aspiration, internal drainage, intratumoral sclerosing injection, or incomplete resection are associated with a very high recurrence rate. Almost all of them will recur. So that's not really suggested. If it's irresectable, then fenestration and complete fulguration of the internal cystic lining can be done. Now I'm going to move on to infectious cysts, so hydatid cysts. So this is caused by Echinococcus granulosus in the vast majority. What happens is that the final hosts, dogs, foxes, etc., secrete larvae into their feces, and then intermediate hosts kind of ingest food that is contaminated by these feces. You ingest this larva, it goes through into your intestine. From there, it's absorbed into the bloodstream or into the lymphatics. About 70% will go to the liver, 20% to the lung, and then the other 10% to other parts of the body. And then once it's in the liver, you have it forms cysts. So you have the parasite part of the cyst, which is your germinal layer and your laminated layer. And then you've got your human part of the cyst, which is your adventitia that lines the cyst. So the rupture of the hydatid cyst will release daughter cysts to secondary sites. And that's just a picture of a scolex with its little hooklets and suckers. So they clinically present initially asymptomatic, and the way they present will depend on the type of the cyst, the size, and where it is. It grows 1 to 5 centimeters per year, and small ones can go undetected for a long time. Large ones may present with signs of compression or rupture. And obviously, it depends on where they are. So you can get cholangitis, jaundice, portal and venous obstruction, Biliary. You can get a bronchial fistula. And if it ruptures, you can also get peritonitis or even anaphylaxis. So in terms of investigations, you may have a full blood count and a diff that's abnormal. Your LFTs are elevated in about half of cases, and your ALP is elevated in almost all patients. If there is a bacteremia, your CRP may be high and you might have positive blood cultures. By doing echinococcus serology, so this will be positive if you've got liver involvement and bone involvement, but it's negative in the rest. It's also negative if the cysts are calcified. So ultrasound would be your test of choice. If it's a complex cyst, you might see debris, daughter cysts, membrane separation, wall calcification. So CT may be helpful. If your wall is calcified, ultrasound might not show you as much. So that's when you decide to do a CT to define the features. And an MRI can also define it, but not really if it's calcified. This just shows a large cyst on the left with peripheral calcification, and you can see the arrows showing daughter cysts. And then on the right, it just shows late phase CT. So there's no enhancement of the wall and internal septations. And this helps you differentiate from neoplasms and MCNs or cystic mets. So this is the Garby classification for cysts, and it essentially just looks at, if there's a double line sign septations, if it's got daughter vesicles, if the wall is calcified or not. In terms of management of these, if they're asymptomatic, inactive, calcified, you just manage expectantly. Chemotherapy alone is not really suggested. It's only if the patient's not a candidate for percutaneous or surgical treatment, if they've got multi-organ involvement, or if they don't really want any interventions. And that's because 40% of hydatid cysts remain active or reactivate after 2 years of just monotherapy. So they recommend if you are going to do a procedure, then start your oral medication before the procedure and continue it for 1 to 6 months afterwards. And then in terms of percutaneous therapy, so PAIR is done, puncture, aspiration, injection, and reaspiration is what it stands for. So this you would consider in patients who have cysts more than 5, who aren't surgical candidates or don't want surgery, or if they've relapsed post-op. This is not really recommended if you've got fistulas or communications with the biliary tree. And obviously you can't do it if you've got cysts that are inaccessible or complicated. Surgery can be considered in patients that have complicated cysts, or if they've got fistulas, multiple daughter cysts, rupture, hemorrhage, etc. And then you can also consider doing hepatic resection that's segmental or lobar. And then liver abscesses. So liver abscesses are encapsulated collections. You've got suppurative material within your liver parenchyma. Low incidence in the US, 2.3 per 100,000, a lot more common in countries like Taiwan at 275 per 100,000. Don't really have numbers for sub-Saharan Africa. Seen in males more than females, and you get infectious, malignant, and iatrogenic. For infectious, the vast majority are pyogenic in nature at 80%, 10% being amoebic, and 10% being fungal. So this just shows the characterization. So malignant abscesses, either primary liver tumors or liver mets, iatrogenic, any sort of biliary procedures or surgery, and then your infectious abscesses, biliary tract disease, diverticulitis, any intra-abdominal infections. Appendicitis, a lot less common cause than it used to be many years ago. So how does it spread and how do you get it in the liver? So it can either happen via contiguous spread, via bile ducts. So if you've got malignancy, stricture, gallstones, via the hepatic artery, if you've got a bacteremia, and then via the portal vein once again with a bacteremia, any intra-abdominal infections, and non-metastatic colon cancer as well. So the etiology and the etiological organisms are basically based on the mechanism that causes it. So if you've got a cholangitis, more commonly for gram-negatives to be Klebsiella, then you get Enterococcus, Bacteroides, and Acanthaomyces as a cause, whereas malignant abscess would be more likely E. coli, Staph, Pseudomonas, seen more with the iatrogenic ones, such as TACE and RFA. Risk factors for liver abscess. So these would be increased age and male sex. So 2/3 of all patients who have liver abscesses are males in their 4th to 5th decade. If they have underlying immune suppression in the form of diabetes or liver cirrhosis, which is associated with a 15 times higher risk of a liver abscess. If they're continuous use of PPIs, and as I mentioned, immune compromised state of any sort. So they present in about 1/3 of patients with fever, malaise, and abdominal pain. 1/4 of them will have jaundice and loss of weight. They can have nausea, vomiting. A small amount will have diarrheal illness. They also get right upper quadrant abdominal pain. And this is because of the inflammation of the liver capsule, if they've got a subcapsular abscess, or if they've got hepatomegaly or gallbladder wall edema. Less frequently, they may have right pleural effusion, jaundice ascites. They can even have a Murphy sign. In terms of investigations, all non-specific, but they might have a raised white cell count. About half of them will have a raised ALT and bilirubin, 85% a raised ALP, and an abnormal INR in 13%. But none of these really tell you that's a liver abscess. So ultrasound has a sensitivity of 85%, and it's important to note that there's a spectrum as the abscess develops. So initially it starts off as a well-defined round lesion. You've got central hypoattenuation with enhancement of the rim and internal septa. And that's because there's increased vascularity there. And then as it progresses to the presuppurative part, it becomes heterogeneous. The borders become poorly marginated, irregular contours. And then as it becomes suppurative, you get a delineated hypodense lesion with a thick capsule. If you see air, it's very helpful, but it's only present in 15 to 20% of cases. So here you can see in A, that's just a hypoechoic collection in the right lobe of the liver. B is just a pigtail they've placed inside. And then here, this just shows a thin inner membrane with very marked hypoechoic perifocal edema. And you can see a bit of posterior acoustic enhancement. On the left, multiple low attenuating lesions that are seen on a CT. On the right, you see 2 big Klebsiella abscesses with a double rim sign, and then you can see quite marked perifocal edema. This just also shows how much the perifocal edema can help you see where the abscess is sitting. In terms of management, so less than 3 to 4 centimeters, antibiotics are sufficient. Success rate is close to 100%. So IV for 2 to 3 weeks, and then oral for 4 to 8 weeks. And the duration really depends on your patient, the clinical and radiological response. Empiric antibiotics should be directed against the organisms that typically cause liver abscesses. Also depends on what you think is the trigger, the etiological mechanism. In general, we give IV ceftriaxone 2 grams daily and flagyl TDS, but you may consider other combinations as well. And if you suspect Staph aureus, then you'd want to add on vancomycin. Drainage can be considered, and that's in patients who don't respond after 5 to 6 days. There's 2 types. You can do a single time needle aspiration and then a catheter drainage. But the catheter drainage has a much higher success rate at 100% versus 68% if the abscess is more than 5 centimeters. And it's also associated with a shorter hospital stay. So you keep it in until there's minimum drainage. You'd also prefer drainage if the abscess is a giant abscess, so that's more than 10 centimeters, or if you've got multiple, if they're in the left lobe, or you can see that there's impending rupture. So the wall is very, very thin and it's at the periphery. So surgery can also be considered, abscesses that are more than 5 centimeters and they're failing percutaneous drainage. There's no real difference between percutaneous and surgical in terms of complication rates or mortality, but it can be used rather in cases with multiple or multiloculated abscesses. So you need to individualize your patient. Look at the number, look at the size, look at the accessibility. Also, if they've got a complication such as abscess rupture or a difficult anatomical position, then you might consider surgery. A laparoscopic, it's safe, it's viable alternative for patients who need surgical drainage, and especially if they failed medical or percutaneous management. So this just shows if it's ruptured, yes, then you should proceed to surgical drainage. If it hasn't, and it's less than 3 centimeters, first try medical management. And if that fails in percutaneous, between 3 and 5, uniloculated, then you can try percutaneous. And if it's multiloculated, then surgical might be the preferred way. But once again, individualize it for your patient. Just a quick note on amoebic abscesses caused by Entamoeba histolytica. It's actually the second leading cause of death worldwide by parasite, with the first being malaria. So risk factors for this: alcoholism, pregnancy, malnourishment, old age, any sort of immune suppression, including steroid use, chronic infection. History, so it would be seen in endemic areas, the duration being less than 14 days, with a history of dysentery during the last few months. They may have fever and abdominal pain. Symptoms also, so the pain, malaise, loss of weight, loss of appetite, sweating, fever. And if it's ruptured anywhere, in the pleural cavity, for example, they might have a cough and chest pain. So ultrasound is the gold standard for diagnosing amoebic abscesses. You get these homogeneous hypoechoic areas, can be single or multiple, vary in size from 2 to 6 centimeters in diameter. You see an incomplete rim of edema, and it can be located near the liver capsule, with septations in about a third of them. Management, if it's non-complicated, you're going to treat it orally, metronidazole, paramomycin, and then percutaneous needle aspiration is preferred to surgery in these patients. If you aspirate, you get that typical anchovy-like paste. In terms of management, also, you need to address social factors. So that's just clean water, hygiene, screening the family members, etc. And then you'll monitor them doing radiological investigations about 6 months afterwards, just to assess for response. Just to bear in mind, there are some uncommon causes of hepatic abscesses: mycobacteria, where we live, candida. They do mention a few other things, but these are very, very rare causes of hepatic abscesses. And then I found this very nice table that just compares all the types of cysts and imaging in Professor Kloppers' article from 2016. You can go have a look. In the interest of time, I'm just going to with that. So take-home messages. So liver cysts have a variety of presentations. The vast majority of them are benign, and your tag 72 can help differentiate a simple cyst from your MCN. Ultrasound is the imaging of choice if it's simple, but if it's complicated, a CT or MRI can be done. Most require a symptomatic approach, and we should individualize management based on our patients, and it's important to identify pre-malignant cysts. Thank you.
Thank you, Des, for that very thorough overview of quite a wide topic. You deserve that water. I'm going to open the floor or the screen for some comments and questions. I'm sure there will be a few. I appreciate it's probably not the first subject a medical gastroenterologist want to talk about, but I'm sure there will be some comments or questions. Your talk was too good. They know everything. Yeah, I guess can touch base on that. obviously, by far the commonest of this whole lot is pyogenic abscesses, well, apart from simple cysts now. And every now and again we get caught out by we missing the cause of the abscess. And although the majority of these days, majority of hepatic abscesses are cholangitic, we still get caught out with a neglected appendicitis with a liver abscess. I mean, we treat the liver abscess with perk drains and all sorts of things and forget about the appendicitis or the diverticulitis. So there's always consider the portal vein spread of the pyogenic liver abscess, because if you do not treat that, you'll sit with a situation where you have portal vein empyema or pyema, and that's just a difficult thing to treat. I see there's a comment. Why can't I see it now? Just a note on amoebic liver abscess. Some side effects almost immediately with first dose of flagyl century sauce and paste. The sauce is yes, sure. Thank you for that comment. Other thing to remember about amoebic abscess that I often see is clinicians or anticipate a miraculous response on imaging, and the hole in the liver takes an awful long time to change. So CT is a bad surrogate of response. So you can do a CT after a month and it might just even look the same. And you did spend a bit of time on the mucinous cysts of the liver. These are exceedingly rare. I mean, it's important, but they're very rare. And it's similar to the pancreas, where we are victims of imaging. So we do more and more cross-sectional imaging for all sorts of reasons. And we see common conditions, which is simple cysts. And it's tricky not to overdiagnose mucinous cysts, because in the liver they are very rare. And they're normally pre-malignant, or that's what we think, but invasive variant is even more rare. So in our whole experience, over 20 years, I mean, we've seen a handful of malignant ones. When you repeat image, there's a question. When do you repeat imaging after drainage? I think after liver abscess, I'm going to answer if you don't mind. It seems a little bit more surgical. You guide it by a clinical response. I think, as I said, the CT picture or what you would normally use after intervention wouldn't necessarily change. So if the patient show persistent signs of sepsis, you will have to re-image, and that might be a short interval or a long interval. It could be a recurrent abscess, a new abscess, a portal vein thrombus. So you've got a good clinical response after drainage of a liver abscess. You do not need to routinely re-image. The other thing to remember is when you put a pigtail drain, percutaneous pigtail drain, or any other drain into the liver, you must not take it out too quickly. So even if the patient do well, you must leave that drain for at least 10 to 14 days. We often see patients home at it. And the reason for it is that it will form a tract. So if you take it out too quickly, potentially a little bit of bile can leak between the liver and the peritoneal cavity, and give bile peritonitis. So just, if you do it per drain, the patient respond well, send them home with the drain and take it out after 2 weeks. Des, I'm going to leave that question to you. That sounds like an awful complicated question there in the chat box.
So in the guidelines, I used the EASL guidelines. It actually mentioned nothing about vasopressin antagonists for polycystic liver disease. So I'm not sure if it has an effect on the liver cysts, but nothing that they mentioned in the guidelines I read.
Yeah, not that I'm aware too. Again, the polycystic liver disease. I saw Nelly was here earlier on. I'm not sure if she's still here. I mean, that is sort of in a practice where I move. It's not a major clinical response. Obviously, the kidneys tend to be the issues in these patients. The problem comes with the liver as soon as you you infect one of those cysts in a polycystic liver disease, you can run into a whole world of trouble. So we tend to surgically stay away from them as far as you can. They hardly, as you described, they hardly ever cause liver failure because the liver is a bit different than the kidney. It will keep on, there will be enough liver parenchyma. Thank you. Great talk. I agree. In case of suspected MCN, to go ahead for a section or aspiration and send for histology because potential malignant. Yeah, this is tricky. But I'm not sure whether tag, there's a refer to tag 72. The last time I checked, that's not available to us in South Africa. I'm not sure. And I don't find that particularly helpful. You shouldn't aspirate them. It's a little bit different than the pancreatic ones. And remember, the pancreatic ones, if you aspirate them for diagnosis, and it's the same principle of malignant biopsies, you aspirate through the area which you're probably going to resect. So you can't do a percutaneous aspiration because then you've got a tract where you're not going to potentially resect. So that's a tricky thing with MCN in our liver. You must have a low threshold to suspect it, but it's very rare. And if you think it's an MCN, so normally that is middle-aged women. It's normally a complex cyst, so not a simple cyst, and it's normally a solitary cyst. So if you, and the cytology is not particularly helpful because it's going to be bland. So if you suspect it and a patient is fit, you should probably resect it. Or one way or another resection. The resection is also technically an issue because if they sit central, it could be quite major surgery for a pre-malignant thing. But there's very little apart from good imaging and categorize the patient in the correct group pre-operative tests that can help you with this. No, so but it's rare. I don't know if that answers your question. More comments. Is Neely still here? I saw her. No, she left.
I don't think on the list of participants anymore.
Yeah, I just on a polycystic. I can't remember of any polycystic livers that we have transplanted it in Cape Town. So I think it doesn't often get to that. And we certainly hardly ever operate on them. Sometimes with the big symptomatic cysts, it's tricky to know what caused their pain, or is that cyst responsible for whatever symptoms the patient might have, be it pain or gastric outlet obstruction or what have you. And it's often not the fittest patients either. So one strategy you can use there is if there's a big dominant cyst that we think could be symptomatic, we drain it percutaneously. We accept that we're probably going to secondary infect it, but you can drain it and see if the symptoms improve, and then you can make a strong case to operate. And it's normally the simplest operation possible because they're not pre-malignant, so you can just de-roof the cyst.
Okay.
And obviously, I don't know where all the participants are from, but we often present these kind of things from a position of privilege where we know we've got access to interventional radiology, aka perk drains. And I think a lot of people, physicians and surgeons, tend to do their own perk drains now because it's just not as readily accessible as we want to. I don't know. You see people here on the chat without access to interventional radiology. In other words, perk drains. Everybody's quiet. Do you have more comments?
I'm tired of talking.
Okay, listen. I thought it was a great talk. Thank you. Thank you for going through the whole series of conditions. I like your take-home message, and I think obviously it's almost always is it infective, a pyogenic thing, and just consider the other ones and simple cysts, and you colored in nicely. So thank you very much for your presentation,
Thank you.
and thanks for Echo UNM and Echo India team for the support. I think this recording will be available on Gastro Foundation's website. I'm sure some of you want to listen to it again. And thanks to Gastro Foundation. And the next presentation is Monday, 4 September, same time, 8 o'clock. And the topic is how are guidelines relevant to my patients on biologics? The presenter will be Professor Johanna Torres. Yeah, and I'm gonna close it with that. Have a good evening.
Thanks very much, everyone. Night.
Bye.